I'm John Kerwin. I'm the Executive Director of Pennington Biomedical Research Center here in Baton Rouge, Louisiana. We're honored to and excited to be part of this new endeavor, defining, diagnosing clinical obesity. Pennington Biomedical has over 40 years of experience in the obesity field, so we've been leaders in this space for decades now. We're very excited to be contributing to this new definition, changing the current views of obesity. Pennington Biomedical was really well represented among this group. We had 3 commissioners, the most of any institutions in the group. They included Dr. Philip Schauer, Dr. Eric Ravison, and myself.
I'm Eric Ravison, and I'm a Boyd Professor in the LSU system, and I was part of the Lancet Commission for the Definition and Diagnosis of Clinical Obesity. The Lancet Commission was a global panel of 58. It started with 58 commissioners. We ended up with 56 at the end, and they are all specialists in obesity, either the treatment of obesity or research in obesity, or in public health and these kind of things, to really tackle the question about how do we diagnose obesity. And the diagnosis so far was BMI, the body mass index, and we changed that. BMI is really an index of corpulence. If you take football players, defensive line, they are very thin. They don't have excess fat, but they have a BMI of 34, 36, up to 40, and they would be characterized as having obesity. Same thing, you have some leaner people who are below 30 and have excess fat. And what we decided was not to throw out BMI, but to add other measurements about really measuring fat.
I'm Dr. Phil Schauer. I am Professor of Metabolic Surgery at Pennington Biomedical Research Center in Baton Rouge, Louisiana. And I was also one of the 50 or so commissioners, international commissioners, involved in this new definition of obesity. Up till recently, we've diagnosed obesity strictly on a measurement of body weight called body mass index. And we've known for many years that this by itself is very inaccurate. There are many individuals who have elevated body mass index, but who would qualify as obesity, but don't really have an illness. They are relatively healthy. So this new definition incorporates measurements of body weight, like body mass index, and measurements of excess fat, what we call adipose tissue, such as waist circumference. So you have to have an elevated body mass index and or another measurement like elevated waist circumference to qualify as having obesity. Then there are 2 additional criteria that are very important. That is signs or symptoms of obesity. In other words, that obesity is adversely affecting your body, whether it is, for example, causing bodily pain, shortness of breath, or adversely affecting a major organ system. Then the 3rd criteria is, does this excess adipose tissue or body fat actually impair your daily living? You know, getting around, doing your work, living a normal life. So those are the sort of 3 components: excess body fat, signs and symptoms of obesity, and does the excess body fat adversely affect your daily living? I think this is really critical, and what's really important is that for the first time we are likely to have universal agreement on the definition of obesity and recognition that in many, not all people, but in many people, it is a disease. So that by itself is going to elevate the international understanding. It's also going to differentiate those who we can prioritize. So these new terms have been developed: clinical obesity and preclinical obesity. Now, someone who may have elevated or excess body fat but don't have illness, we call that preclinical obesity. They may be at risk over time for developing what we call clinical obesity. But it is those that have clinical obesity that's causing signs and symptoms and affecting their daily activities. Those are the folks that we should probably prioritize. Now, for example, it's estimated in the United States nearly 40% of Americans have obesity based on the old criteria, an elevated body mass index. Now we know that not all 40% actually need treatment. We can now really focus and hone in on, of that 40%, how many actually have an illness, and we can prioritize on that population who actually need the treatment the most.
You have heard that basically we have the old classification, which is basically underweight, normal weight, obesity class 1 and 2 and so on. And here, this is an example of different conditions that you can see. You have somebody with a BMI of 23.7 here, no excess body fat, then there's no obesity. Then you go to the second case, 28.8. This is somebody who's overweight by the old diagnosis, but there is no excess fat in this person, and therefore there's no obesity with a new classification. Then the second one, which is the third one, the third one, 28.8 of BMI, overweight by the old definitions, but now and there is excess fat, and as you know, you have people who are just overweight but have excess body fat, and you can measure that by CT scan or by MRI, by DEXA and all that. And this person has preclinical obesity because there is no sign or symptoms of, like Francesco Rubino defined, of function or illness of organs and tissues. Then the fourth case here, 32.4, that's obesity by the old standard, but this person is maybe a football player. No excess body fat, high muscle mass, and sign and symptoms none at all. And this person has obesity by the old classification, but no obesity here, because there is not the excess fat and none of the symptoms. Then you go to the 39, number 5 here, 39.2, and you have excess body fat, which which does confirm obesity, confirmed obesity, but there is normal or slightly lower muscle mass, but no sign or symptoms of dysfunction of organs or tissue. And this person, despite the BMI of 39.2, would have preclinical obesity by the new definition. And the last case, of course, is again 39, but this time you have excess fat, you have symptoms and signs of tissue or organ dysfunction, and here you have obesity by the old classification and clinical obesity by the new classification. Now, let me go, I'm going to go directly to this. Now, the new diagnosis, you need confirmation of obesity. Ideally, we heard Steve Whip the other day, and he has all these methods to measure body fat, not DEXA, because it's not, we're not going to get DEXA in, except in specialized centers available. But you need a BMI above 30, let's say, and then you need a confirmation of excess fat. Now, is that just waist circumference? I don't think so, personally, because BMI is quite correlated with waist circumference. but the waist on hip circumference ratio is something else. And I think here they are not as well correlated, and I think that this would be a confirmation of confirmed obesity. And of course, if you have the DEXA or a BIA or the 3D picture, which seems to be very well correlated with percent fat measured by DEXA, you would have confirmed obesity. And after that, you know, if you have, yes, you have confirmed obesity, then you have to have this medical history, the physical examination, and the standard blood test. All these are necessary now for clear diagnosis of one of these 18 conditions which are written up in the report showing sign and basically symptoms of dysfunction of tissue or organ, and then you end up with clinical obesity. If you don't have any of these symptoms or signs, you may have confirmed excess fat, but you would have preclinical obesity, and like Francesco Rubino presented, it is basically reducing the risk of developing some of these dysfunction or illness of organs and tissue. Here, this is basically a simple slide showing us, you know, what are the causes of obesity, and now we are all in this field here at the Pennington. You have confirmed obesity by 2 measures, and then it's either preclinical obesity and it's a risk to health, and the treatment goal is really monitoring these people, following them up, and trying to have them reducing this risk. It can be lifestyle, it can be diet or physical activity, and all these kind of approaches. And then clinical obesity, then there is a treatment goal like Francesco presented with a therapeutic intervention. From the BMI-based classification to a clinical diagnosis of obesity, implication for care and policy, because now the work is really going to start.
Well, thank you, Eric, for setting the stage for us. We have a very mixed audience here today. I've thanked some of the people who have contributed, but I want to acknowledge Paula Pennington as part of the Pennington Center itself, and the family and the foundation are here. A lot of media here, and so we have, of course, a mix of our faculty. But this is meant to be an interaction. We want to hear your opinions, your views on what you've heard, what has been written about this new classification, which we now call clinical obesity. What that means to you, and what it might mean in your life, or in your practice, or in your science, or in how you're communicating all of these messages out to the rest of the world.
It might just be helpful to start off with the importance, the historical importance of this recognition. We've known about obesity literally for centuries. It was noted in the earlier presentations that it wasn't until 1948 that the WHO was the first to consider it a disease. And then over the last couple decades, other organizations, whether it's NIH or the Obesity Society or the AMA, started calling it a disease. But even with that, the actual clinical definition was quite inaccurate, based solely on body mass index. And we have known for a long time the weaknesses of using body mass index, which is a relationship between height and body weight. We've known that for a long time. So finally, and this was really a delight to be part of this, quite challenging, 2.5 year, every month, all of us getting together early morning to discuss this, and lots of different opinions among renowned scientists, but coming together to nail down this clinical diagnosis not only reflects a number, but also this concept of illness, which is, bodily harm to an individual. And I think this is going to be overwhelmingly important as this field moves forward, especially speaking as a clinician, to properly educate and more clearly diagnose obesity so we don't overtreat or undertreat it. And I think our patients are going to appreciate it as well, because many of our patients recognize that their BMI doesn't necessarily reflect illness. So.
Thanks for that, Phil. And John, you were walking to the mic, and feel free, folks. We need to use this mic here for the videoing purpose. So, if you would just move to that mic if you've got a comment, question, any observations.
So my question is, what other disease uses end organ damage as diagnosis? Because when I'm sitting here thinking about this, you can go from, I can maintain my body weight from preclinical obesity to obesity and get clinical diagnosis. So what other disease can I not change what you're measuring and still go from preclinical to clinical diagnosis? And so I'm struggling with that, because at least with BMI, you had to increase from overweight to obesity to get classified as obesity. With diabetes, you have to go from pre-diabetes to diabetes to get classified, and your hemoglobin A1C or your fasting blood glucose goes up. With this, my adiposity can be maintained, but I go from preclinical to clinical obesity. And so I'm struggling with that, and what were the discussions on the panel about that?
Yeah, there was a lot, and that's a good point, but you're actually making the case for the very definition itself. It is independent of the level of adiposity that you might maintain. And so these issues relative to preclinical obesity are focused on health and on signs and symptoms, as opposed to your actual BMI itself or your weight. Phil, you want to weigh in?
Yeah, exactly. And I think also when we talk about adiposity, the concept of excess adiposity, these other measurements, waist circumference, waist to hip ratio, presume we're talking about the differentiation between visceral and subcutaneous. So it's not just the excess quantity of adipose tissue, but where it's coming from. You can have two people with the exact same BMI. One has a large waist circumference, one has normal, and they may have exactly the same quantity of excess adipose tissue, but where it's deposited is also very relatively important. And maybe Eric could add to that, because I think you alluded to that in your examples.
Yeah. Yes. John, I think it's a good question, and it was really discussed tremendously. And these 18 conditions, if you have preclinical obesity, there is a encouragement for risk reduction, but also there is a continued follow-up of these people by the clinicians, and with an assessment of all these tissue and function. And you have seen a couple of times or 3 times this human person starting from the CNS, going down to the respiratory system, going down to the gut and the liver, going down to the joints and all these kind of things. And they should be part of the assessment and see, plus also some blood measurements to see if there is a transition towards one of these dysfunction or illness of an organ or a tissue.
So is there another drug, another illness that uses these endpoints for clinical diagnosis, such as this, like end organ damage, something like that? What other disease gets the same diagnosis, a similar diagnosis? Like what would be a similar disease that would get a similar diagnosis, such as obesity? Does that make sense? That would use these criteria?
I think the challenge, and I'm going to show some slide because I have been asked to look at the prevalence of these 2 conditions in a database, which is the All of Us database. The challenge is really, what are these dysfunction or illness of tissue and function which is really due to excess fat. And I think that this is where the judgment of the clinician is very, very important. The medical history is important, and the follow-up of these, because you'll see, I mean, you have people with pulmonary problems who are very, very thin, and they were smokers, and they had all these respiratory problems, like Bob Eckel showed with the pre-disease versus the disease, HIV versus AIDS, or he showed osteopenia versus osteoporosis and all these kind of things. Now, what are the conditions? You know, I'm not a clinician, and I don't know you guys.
Well, just to add, John, I think to answer your question, I think the majority of diseases are diagnosed based on signs and symptoms. So you'll pick a disease, arthritis, for example. There is the symptoms, pain, for example, inflammation. Pick a disease, and there is almost always a sign and symptom. If there is no sign or symptom, then there's probably not real disease there. It may be more of a preclinical condition.
Very interesting discussion. Again, I didn't have the chance to see the 18 criteria that were described for adults and the others that were discussed for pediatric and adolescent populations. And again, establishing the diagnosis of obesity in terms of excess fat by whatever mechanism. So you have obesity, and in the absence of signs and symptoms, that's preclinical. What I want to bring up is the issue of the psychological impact of obesity. You could have an individual that is obese by the objective criteria that we discussed in terms of excess fat, that is very happy individually. And you check for organ dysfunction and everything is okay. You have another situation where that person with no signs or symptoms of organ dysfunction, but documented obesity, excess fat, that is very unhappy with his looks, his personal situation, anxiety. If we're facing that kind of situation, do we categorize that patient as clinical obesity? Because the obesity is having an impact in terms of psychological function, anxiety, depression, and things of that nature. Was that included among those diagnostic criteria?
Go ahead, John. Well, no, I think that's a great point, and they pointed out 3 criteria. One is a measurement of excess adiposity is critical. Number 2, signs or symptoms, or if the condition is affecting daily living, daily activities of living. So this individual you described, whether this is a person who's got depression or some related, one could argue, boy, that's CNS. That's affecting the central nervous system, and or that is affecting that person's daily activity, getting through their day healthily. So I think that would potentially qualify.
Thank you.
But I think, Juan, that's an important distinction. But I think this person who is unhappy, borderline depression or having depression, is likely to transition quicker towards clinical obesity with an organ or tissue dysfunction. And I think that it would be in my view, somebody to follow a little bit more closely than the happy, non-dysfunction person.
Well, Eric, what I'm saying is that person may already qualify as having clinical obesity. Do you not agree?
If it is a impairment to the everyday living condition of this person, yes.
Yeah, okay.
But if it's not.
Right.
Yeah, that would be my opinion also, that if that is a manifestation in terms of interfering with the functioning of that individual in the absence of any laboratory abnormality or other indication of organ dysfunction, I think that should be considered clinical.
Yeah, Juan, I think you're pointing out some of this sort of gray area that will probably have to be sort of sorted out over the next few years as these guidelines actually, permeate clinical practice.
But some of that too, one is covered under mental health and the contribution of the psych and psychiatric conditions that may go along with having excess adiposity for these folks. So it's covered in that domain. It's also covered, as Philip pointed out, in the other domain where we look at activities of daily living. And it's covered in the first domain because you've identified excess adiposity. To be a disease, though, it has to have, in this context, the excess adiposity has to impact the specific signs and symptoms that you're evaluating. That's a real challenge in the field of both psychiatry and psychology that is to be developed over time. But that's the opportunity that we have as investigators to pursue. Amanda?
Hi there, Amanda Stiano here, faculty at Pennington. And in thinking about pediatrics, I think those signs and symptoms, that table will be very helpful for pediatricians, pediatric healthcare providers. It really guides them on what evaluation they need to be doing, what they need to be monitoring. The one piece that I see as concerning, as well as from Dr. Bauer's presentation, is that definition of what is excess fat and abnormal fat distribution in the pediatric population. And so Dr. Bauer mentioned we shouldn't abandon the BMI percentile and growth chart, which I think is smart, that's a good initial screening that physicians should be doing. But there doesn't seem to be a universal definition of those metrics in pediatrics and children and adolescents. And it seems inappropriate to just use the adult standards because sometimes those are quite high for smaller bodies. So I'm curious your thoughts or the discussion on that. What is a waist circumference percentile, or what is, even if the child gets a DEXA scan, what is a percent of body fat for an adolescent girl going through puberty, at which point you would be concerned? My second tag on then is, as we're trying to settle that as researchers and clinicians, is there a concern that we are creating barriers to providing treatment, getting insurance coverage, if we set some of these definitions up before the patient could access treatment for clinical obesity?
That's a great point. And one of the things that this commission represented was that we have on that commission, not just Professor Bauer, but many other pediatricians who, Natalie, who presented early in particular from World Health Organization, really brought to bear the distinction between adult obesity and pediatrics. And within the paper, you will find a whole section there on pediatric obesity. We were not careful, but we made a decision to only report out on the adult criteria for waist-to-hip ratio, waist circumference, and so on, because those are very well established, accepted, and that was the direction that we felt we needed to emphasize. We didn't include the pediatric piece because we felt that was something that needed to be developed. It's debated within even the pediatric community, and so there is work still to be done there. But we're very cognizant, and you'll see that within the paper itself. And it was every, I would say every meeting, some aspect, every topic that was covered. Steve was an expert that we brought in to consult on body composition. There were questions on, well, how do you apply that to kids? So it was a big part of what was done. The main emphasis was on adult obesity because that was the charge, but we didn't neglect the pediatric. But there is still work to be done there.
Yeah, I will turn that back to you, Amanda. I know that you're recently involved in this very large consensus statement by the American Academy of Pediatrics. I think, wasn't that a big issue in your statement? And perhaps maybe you could share with us what you think those parameters of excess adiposity should be in the pediatric population.
Based on the clinical trials and the data available to us, offering the intensive health behavior lifestyle treatment at 85th percentile and above is what's recommended by the American Academy of Pediatrics, knowing that counseling for weight management, positive behaviors, we're helping the parents establish a healthy household and healthy environment is really important from early ages, in the hopes that we can prevent then the clinical obesity and the long-term serious health consequences. So I think trying to thread that line, because here in the States we've been trying to push for the intensive treatment and early recognition of obesity based on BMI percentile, and so then making sure if pediatricians or others see these guidelines, they understand that this is going to help them throughout the treatment course as we're monitoring health and organ-related dysfunction, but to not withhold treatment. Because some of these adolescents may even be eligible for medication at a 95th percentile. And we wouldn't want to confuse health, insurance providers or family members or physicians to provide a contradictory message to that.
I think that's the goal probably of the next commission. This one, as Dr. Rubino and I think others had mentioned, there wasn't much discussion about treatment or even preventive strategies. The goal here was to just clarify these distinctions, preclinical, clinical, and then that would probably be the next goal is, what is preventive therapy, what is treatment?
And if I may add one more thing, how to operationalize even some of the evaluation of the signs and symptoms in the pediatric age range, and then certainly the body fat measurement. Because it's tough to get waist circumference on kids. Most people don't have access to DEXA. And then even some of the other evaluations may not commonly be being done in primary care. So what are the ones that we need to really educate our providers on and equip them with to make sure that they're actively monitoring these things?
But I think that the body fat itself is a big problem because, what is excess fat? Is it 25% in males and 35% in females, like we tend to believe? Unfortunately, unless diabetes, where you have a bimodal distribution of the 2-hour glucose after an OGTT, or even the fasting glucose, it's not the case for fatness, and therefore this threshold, excess fat, even if you measure the fat by DEXA or whatever, has to be defined.
Thanks, Amanda. Jackie?
Sure. Jackie Stevens, Pennington Biomedical. I guess one thing I'm worried about is, access to treatment for people with preclinical obesity. So, sure, maybe their healthcare provider writes them a prescription, to one of these very effective incretin therapies. But the insurance company doesn't fill it, either because that's the policy of the insurance company, and we know this is an issue that's real. And so I think, people in that category, whether they have preclinical obesity or clinical obesity, have that issue. And now I think it could be exacerbated if you have this preclinical obesity. To me, I worry that it's going to give the insurance company a license to say, hey, we don't need to treat these people. But I do think that the risk that they have from being obese is legitimate. And if that person wants to treat that, the healthcare providers should engage them.
That's a great point, and that's a big. I think this is going to be a big part of the ongoing discussion around these guidelines, dividing it out into preclinical and clinical, the implications for treatment, and the costs associated with that. And you heard some of that sentiment from some of the earlier speakers. From a health perspective, the cost associated with treatment today with the new medications is exorbitant. If you take statins as an example, you can treat a patient with statins on $85 a year. For the current GLP-1s here in the U.S., you're paying $1,300 a month, and some of that cost, of course, is associated with development, and we're in a very early stage of this kind of treatment, and I fully expect that those costs will come down, and you would want them to be in the realm where you have statins today at $85 a year for treatment, but that's not where we are, and the challenge we had, and I think the challenge going forward, is, again, with the payers, the insurance providers, in terms of what they will support. I would ask you to think, if you have pre-obesity and you don't have any organ dysfunction, then what are you treating? You're treating the weight, perhaps, and that's what a lot of these drugs do. The intent there was to treat disease, and so you don't have disease until you have some organ dysfunction driven by the adiposity and or a deficit in ADLs.
Sure, I understand that.
Okay.
And, perhaps, these people are metabolically healthy, but we know obesity puts you at risk of at least 13 different kinds of cancers. So, that's another factor. So I think that I think risk is really important, I guess, is my perspective.
Yeah.
Jackie, just if I may intervene here, there was so much discussion about this. You can imagine in 2 years that, are we hurting a certain part of the population by excluding them? On the other hand, 40% of Americans, based on the old criteria, have obesity. And those with the more advanced obesity, most of them are getting nothing, okay? So at least with this preclinical versus clinical, it's somewhat of a prioritization so that those with clinical obesity, many of whom are getting no evidence-based treatment, we can focus on those folks first. And I think that was the sort of the yin and yang of that argument.
Thank you.
Hi, Hannah Cabre. I'm a postdoctoral fellow here at Pennington. My question is about recruitment for clinical research studies and how you foresee this changing the recruitment criteria. Specifically, now we use BMI categories. Do you foresee us trying to recruit only clinical obesity versus pre, or would this be a retrospective analysis in our study designs? Thank you.
Yes, I think I never thought about that, and I think it's an important question. But as you know, for studies we have BMI categorization, but then there's always other inclusion and exclusion criteria. We don't want people with an OMA-IR above 3, or we want them, and all these kind of things. And I think it's going to be a little bit a la carte. But do we accept only people who have 2 measurements of excess fat, including maybe BMI, but also the waist on hip ratio or the DEXA fat and all that? It's all questions to be resolved. But I think, once again, it's going to be a progressive evolution and targeting this organ or tissue dysfunction. I mean, if you want to look at the impact on mobility in older folks with obesity, I mean, you are going to have a walking distance for 6 minutes as inclusion or exclusion criteria, or these kind of things. But I never thought about that, and I don't think it was discussed.
Well, only barely, because this was primarily a clinical focus. So these are guidelines for practitioners, and really to change how that approach is done. But what it does is it opens up the opportunity for research. And we were on a call, Phil and I were on a call last night for a major bariatric study, and we realized that, if you redefine the population based on these new clinical guidelines, you may be able to answer a different question. So that is the opportunity for the folks out here today. Not defined in the paper, but to be done.
It's going to be a long process. First, I mean, public health system adopting this recommendation, and then insurance covering for the treatment of clinical obesity, and also helping those people with what we call preclinical obesity. And I think it's the start of a process which is going to last years, and there'll be a lot of refinement over time, but at least we are departing from just corpulence, and now we talk about excess body fat.
I think, the average, American will be able to appreciate now a much more clear and practical definition of obesity. There are many folks who correctly have told their doctor, yes, I'm overweight on the scale, but I feel okay. I can function normally. In the past, we would have labeled that as obesity. But now, that person would be more likely designated as preclinical, not having disease yet, but at risk for it. And the strategies of care will be different. More focused on monitoring, more focused on preventive measures such as good diet and exercise, as opposed to treatment such as medications and surgery. What is sobering is that rates of obesity, not only in America but across the globe, are increasing. And the impact of obesity on the daily function and the longevity of humans is increasing enormously. And hopefully one additional benefit of this commission will be to shine another light on how important this condition is, and that we really have to enact public policy at better strategies for prevention, but also for those that have obesity who are struggling, better access to evidence-based treatment, whether it is medications, particularly some of the newer medications that are highly effective, the GLP-1 receptor agonists that we all have heard about lately, and also for some people, bariatric surgery. These are two entities that have been shown to be quite effective and quite safe. Pennington Biomedical has a website that will have a lot of information, about this commission. So I'd encourage that. It's pbrc.edu.